Good afternoon, everybody, and thank you very much for attending the Zoom meeting this afternoon. And we're going to be having a wee chat about MECFS diagnosis and management today. Yeah, welcome any feedback that you've got would be really great. Okay, so what we're going to cover today is we're just saying hi, which we've just done, and then we'll do a little bit of a background, talk about MECFS, about what's known about it, what's not known about it. We'll look at a bit of a definition about diagnosis, how to get diagnosis, what sort of impact it has on people's lives. And then hopefully we'll be able to spend a little bit, most of our time today talking about management, because that, after all, is what we all want to know, how to live with this illness. But before I start, I just wanted to talk a wee bit about the Godwit, because you may or may not know that the Godwit, or the Kuaka is the Maori name for it, is the symbol for MECFS Canterbury. And if you don't know much about Godwits, they're actually an amazingly remarkable bird. They make one of the longest migrations known in the world from New Zealand to Siberia every year. So when it comes to March, they all collect in various places along the New Zealand's east coast. Some of them here in Christchurch. A lot of them leave from Thames Estuary, close to where I used to live a few years ago. And then in around about March, they all start to make this very, very long trip of 12,000 kilometres north to Siberia. On the way up, they stop for a wee while around the Yellow Sea, around China and Korea, just to feed and rest, and then they continue. And then they spend the northern summer in the around Siberia, northern hemisphere, and then they travel back here for the start of our spring. And when they travel back, they travel non-stop. They do that entire flight in a straight line, non-stop, from Siberia to New Zealand, nearly 12,000 kilometres. So quite an incredible feat, one of the most amazing feats in the animal kingdom. And so the birds take turns to lead. And then they conserve their energy in the slipstream of the other birds, a little bit like geese when they fly in formation. And some birds have made this trip 20 times or more. It's absolutely incredible. So MECFS Canterbury have chosen this animal because of its spirit of endurance and cooperation in the face of enormous challenge. And I think it's a really fantastic symbol. All right, what do we know about myalgic encephalomyelitis, or chronic fatigue syndrome? What we probably don't know is a lot more than we actually do know about it. And I'm sure all of you have got some facts and figures at your fingertips, but yes, it continues to be a little bit of a mystery in more ways than one. But what we do know is that it's a very debilitating illness and a long-term illness. And it's been classed as a neurological condition by World Health Organization in 1967. So that's really important. It's actually been classed as a neurological illness. It's also been called Tapanui flu. It's been called the yuppie flu. It's known, of course, as chronic fatigue syndrome. And it's estimated that between 4 and 8 people in 1,000 have the illness. Now, that's pre-COVID. Since we've had COVID, the numbers have definitely gone up. But so we're looking at probably around about 3,000 people or more in Canterbury, and about 10% of those are young people. It affects all ages, it affects all genders, and it affects all ethnicities. It's pretty widespread throughout the world. However, it is diagnosed a lot more in women. And the onset, there seems to be 2 bands of ages that are quite common onset. One of them is adolescence, and the other is kind of midlife. between 30 and 39 years is a very common time for people to be diagnosed with it. But it has been seen in someone as young as 2 years old and diagnosed for the first time in someone as old as late 70s. So it's across the spectrum. There's no known cause that people can put their finger on, but for about 3/4 of people, their illness was the onset of the MECFS was preceded by a viral illness. Very common to have glandular fever or the flu or COVID-19 are often seen as triggers for this illness, but it can also be other events can also precede MECFS, like ongoing stress, a major traumatic life event, environmental stresses, mold and chemicals have also been suspected as well. And there also may be a genetic predisposition, and you may find that if someone has MECFS may also have other illnesses or may have someone else in the extended family who has it. So what else we know about it is that there are no diagnostic laboratory tests available. But there are a number of things that are actually going on. So people who have MECFS show an abnormal physiological response to exercise. So there have been tests that show between normal healthy controls and people with MECFS are tested on day one with a vigorous physical challenge, and then 2 days later are challenged again. And whereas they perform quite evenly on the first day, on the second day of the challenge, the MECFS people performed really, really poorly in comparison to the healthy controls. There's an impaired energy metabolism at the cellular level. So we know that at the cellular level, there's something going on that the cells can't access the energy that they require to function normally. And whether it's nutrients or oxygen, it's a little bit uncertain. And then there's really measurable abnormalities in all of our other kind of systems, in the immune system, the nervous system, the cardiovascular system, endocrine, and the gut as well. There's definite differences in people who have MECFS. However, as we all know, and as I just said at the beginning, there are no tests to show this, and people will go to their doctor, have a whole barrage of blood tests and other tests, and everything will come back normal. The doctor will say, "Isn't that amazing? Everything's wonderful. Your tests are normal." Well, we all know that everything's not wonderful. And in the past, MECFS has been incorrectly attributed to psychological causes. It is definitely not a psychological illness. And at the moment, there is no approved treatments or medications for MECFS. So the focus is on management of the illness. And here's quite a nice kind of a slide from Emerge Australia, who've just sort of shown what I've just talked about in kind of a nutshell. So it's a complex and disabling disease. It affects the brain, the muscles, digestive system, immune system, and the cardiac system. The hallmark symptom, the main defining symptom of MECFS is post-exertional malaise, and it's been classified as a neurological disease by the World Health Organization. And as you see with the diagram on the right, all of these signs and symptoms can be apparent because of all the different body systems that are involved. So it's not just about fatigue, it's a huge number of different signs and symptoms that people experience because of the effect on their body systems. So in 2015, the Institute of Medicine, the American Institute of Medicine, got together and they looked at everything that was known about CFS, and they published a landmark document, and in that document they established the main criteria for diagnosis for MECFS. beforehand there hadn't really been anything sort of set in stone. So the first thing that is required for diagnosis is a greatly lowered ability to do activities that were usual before the illness. So this is always accompanied by fatigue, not really alleviated by rest. Has to last for 6 months or longer because it has to be a new thing. With children, it can be 3 months or longer. It's not a result of increased exertion, and people often can't work or attend school. They have a lot of trouble completing just ordinary activities of daily living, like preparing meals, having a shower, can be greatly impacted. And up to a quarter of people are bed or housebound because of it. So that's the first one, that greatly lowered ability to do activities accompanied by fatigue. The second symptom that we need for diagnosis is post-exertional malaise. And this is really the hallmark symptom of MECFS. This is something that happens in MECFS and not really seen anywhere else. And what that means is a worsening of symptoms after physical or cognitive activity that normally wouldn't have caused a problem. So it's individual for everybody what this would be. For someone who used to jog and climb mountains, the trigger will be a lot different from someone who has had a quieter life and not really done a whole lot. So for everybody, and also the extent of the illness affects how much it will take to be a trigger. But when you get post-exertional malaise, people are often very unwell, often describe it as feeling like they're coming down with the flu, achy, swollen glands, sore throat, skin sensitive, all of those sorts of things, and an increase in other sorts of symptoms that might not normally have happened. So the sleep's affected, brain fog's worse, everything kind of feels worse when you have post-exertional malaise. It may need bed rest to help it go away, and it can be a result of just doing too much on one occasion, or maybe slightly too much over a period of time, and you just kind of get that catch-up sort of happening. And often people aren't even aware that they're just sort of going beyond their energy envelope. It's just can be just a very slight overdoing it over time. And the third main symptom is sleep dysfunction. So people who have MECFS describe unrefreshing sleep. So you get up in the morning and you sometimes feel worse than when you went to bed. You can sleep longer than usual, often have to sleep during the day, and sometimes you've got other sleep issues accompanying it as well. So people will talk about insomnia, or if they go to a specialist, they will be diagnosed with sleep apnea or restless leg syndrome. There's often other sleep kind of things going on as well. So those are the three primary symptoms that people need for MECFS. And then as well, you should have at least one of the following symptoms as well. So the first one is cognitive impairment. So this is like reduced stamina to do mental and cognitive work. It's worse when you're in post-exertional malaise, and it's seen in things like having short-term memory loss, can't hold conversations, you lose words in the middle of a sentence, can't think of what you want to say, following the thread of conversations really, really difficult. Multitasking is really difficult, and having to sort of think on the spot and think quickly about what you need to do can be really, really impacted as well. And then either that or orthostatic intolerance. And this is a worsening of symptoms when you, what they say, assume an upright posture. So if you go from lying to sitting or sitting to standing, you You get increased dizziness, your heart might race, your heart might pound in your chest, you get dizzy, you get lightheaded, you might feel like fainting, you could feel nauseous, you might get headaches. All of those things kind of sit under the umbrella of orthostatic intolerance, and there are a few conditions in that as well. So this is kind of the diagnostic picture for someone who has ME/CFS. And then in addition to that, people often also have a lot of gut problems, a lot of issues with pain, and a lot of other sorts of things going on as well. But this is probably the core things that a doctor needs to see to give a diagnosis of ME/CFS. And just a little bit more about post-exertional malaise. So, as I said before, it can be just a little bit too much over time, or one big event that causes it. And you might feel the post-exertional malaise straight away, like you might go and do something, and then you come home and think, oh, I've really overdone it. Or you might do something, feel really good, and then the next day or 2 days later, suddenly you're feeling horrible, fluey, really awful, thinking what's going on, but the onset can be very, very delayed. It can go on for ages. It's not something that a little rest in bed will fix. It can go on for days or weeks or even months before you come back to your previous baseline. And the intensity of it can sometimes be disproportionate to the thing that set it off. So it might just be a little thing that you did, or you think it's just a little thing that you did, but you can have quite severe post-exertional malaise as a result of it. For some people, ME/CFS is progressive, and every time they have a relapse or a bout of post-exertional malaise, they never quite get back to the previous level of functioning that they had. And so, therefore, we'll talk a bit more about it, but the aim with post-exertional malaise is to try and reduce it as much as possible. And it's really important to know that post-exertional malaise is not a result of deconditioning. So it's not because you're unfit, it's not because you're not exercising enough, it's a physiological response to your illness. And here's just a few comments that people have made about what it feels like to have brain fog. And I think a lot of these things are pretty pertinent. It's not just going into a room and forgetting why you were there. So, what are some of the obstacles to getting a diagnosis? And I'm sure people who've been down that path can experience some of the frustration of first of all, not knowing what's going on themselves, but secondly, then not having a medical professional validating what the experience is. But sometimes it's very difficult for healthcare providers to actually come up with a diagnosis. And this is a wee list from Kathy Stevenson, who's a New Zealand GP who talks a lot about ME/CFS and educates other GPs. But some of the things that she's identified is that, and of course we all know there's no lab test or biomarker for ME/CFS. So you can have all of these normal blood tests, and that leaves, can leave doctors scratching their heads. The other thing is that fatigue and a lot of the other things that people experience are also experienced in other illnesses. A lot of illnesses, people have lower level energy levels, experience a lot of fatigue, can't function the way they used to, have problems with orthostatic intolerance, things like that. So a lot of these symptoms can be a little bit non-specific. Sometimes healthcare providers see the person sitting in front of them and can't recognise that they're ill because, as we all know, people with ME/CFS go out when they're feeling well, when they're feeling able, and often that little surge of adrenaline is enough to kind of make you present in a very kind of normal, in inverted commas, way. So it's very difficult when they see somebody sitting in front of them who looks normal, describing a whole lot of symptoms that are obviously they're not experiencing that day. It can be a little bit hard to make that picture fit. The disease is very unpredictable in the way it presents sometimes, and I'm sure everyone's had that frustration of committing to an activity a few weeks down the track, and then on the day waking up and thinking there's just no way I can do this today because of how I'm feeling. And it's a very unpredictable sort of presentation of how you're feeling. Symptoms vary a lot, so everybody experiences this illness in a slightly different way. And the most severely affected might not be seen just because they just can't get out of the house. And sometimes people have had such a lot of health care exposure because of all of the things that have happened to them that sometimes the picture gets a bit cloudy. It's very difficult to describe clearly what's going on, and you might have had previous misdiagnoses and things as well. And last of all, the medical community still doesn't know a lot about MECFS, and it can be very difficult to find someone who knows a little bit about it. And I think this just sort of describes a little bit of what I was just talking about, is that people with MECFS are only seen when they're well enough to be out and about. And what are the things that make MECFS so debilitating? Well, all of these things that we talked about, previously, the fatigue, the sleep dysfunction, the ongoing sleep dysfunction, the lack of a good night's sleep, the brain fog, trying to just get your thoughts organised, the pain that kind of distracts you from everything else, all the other conditions that you've got, the sensory hypersensitivity that can't bear the loud noises or the bright lights, problems with your gut, the post-exertional malaise, and the fatigue. All of those things are really, really hard and impactful. And then you have all of these other things that can be on top of it as well. So there can be a lot going on, and all of it sort of very, very impactful. So it gets in the way of your work, gets in the way of education, it gets in the way of having social and personal activities. Everything suddenly becomes so much more limited. And it's been calculated that the degree of impairment can be worse than people who've got rheumatoid arthritis or MS or depression or heart disease or cancer or lung disease. And we all think of those as being quite serious kind of illnesses. Around about 3/4 of people with MECFS can't work or can only work in a very limited way. And about 1/4 of people who have it so severely that they can't leave their bed or their house. And within your own personal spectrum of illness, the severity can really fluctuate. So that on bad days, you can be stuck in bed even though you may function fairly well on other times. And it's very, very up and down, it's all over the place. And as I said, sometimes that makes it very hard to plan your life. And just another wee graph that just talks about the spectrum of severity from mild, from people who can be up and about, looking after themselves. They may be able to work, but it probably is work at the expense of most other activities. You probably, a lot of people I speak to say, yeah, I can work full-time or part-time, but I spend all weekend recovering and I don't have time or energy for anything much else in my life. And then that can go right through to very severe, where people need to be cared for, where they have extreme sensitivity to light and sound, where even rolling in bed, over in bed, may be enough to set off post-exertional malaise. And then in between, there's the whole range of impact. And as I said again about this being an invisible illness, these are the sorts of things that people don't see and don't recognise, and I've had so many people say to me, if someone else says, oh yes, I get tired too, she said, I'm going to clock them, It's much more than just being tired. It's about having to really work up to leaving the house. It's having to rest after the smallest of tasks. It's having to really the way it impacts, how you feel about yourself and your life. Having to spend a huge amount of recovery just to do one thing that you might want to do. And there's that whole thing about the loss of what could have been as well. So there's a lot to think about. There, as well as MECFS, people often have other illnesses coexisting. We talked about comorbidities. So people with MECFS and fibromyalgia share a lot of the same kind of symptoms. There's a lot of overlap between those two illnesses. And sometimes they coexist, but often with fibromyalgia, widespread pain is the most outstanding thing, whereas in MECFS, it's the post-exertional malaise is the biggest issue. Ehlers-Danlos syndrome is also, there's a lot of overlap with MECFS, a lot of signs and symptoms are shared. Sometimes they coexist, but they are different conditions. And then mast cell activation syndrome, which is seen through a whole range of other conditions, often coexists as well with MECFS, and has its own set of challenges that must be managed. And then a wee word about long COVID as well. So most people with COVID-19 recover, but some people have ongoing symptoms. And at the moment, there's no agreed diagnostic test for long COVID, but the World Health Organization has stated that long COVID can be seen when people have ongoing symptoms 3 months after their initial illness, and the symptoms last for more than 2 months, and they can't be explained away by another illness or another diagnosis. And so it's thought that up to a third of people who get sick with COVID-19 will go on to have long COVID, and about half of them will meet the diagnostic criteria for MECFS. So management principles, and I know that the cats are not talking about management, but I did quite like that slide, so I just wanted to put it in somewhere. So the main things with management is it's about a few sort of main principles. I guess the first one is how you organise your healthcare team, because there can be a lot of people involved in your life in a helpful way to help you manage your illness, and sometimes it can be a wee bit overwhelming. So it's about kind of having a wee bit of control over that. And I think the second thing is about having a stepwise approach to the management of the illness. As we said, there's no cure for MECFS. It's about managing the symptoms and treating the symptoms. And sometimes it's helpful to think about putting the symptoms in a priority or in an order, and then sort of trying to tackle the worst, most pressing first, and making your way down through the list. The key to managing MECFS is to incorporate pacing into your life. That's probably the most important skill that people can learn. And medications, when they're used, it's about being very careful because most people are very sensitive to them. And again, trying new treatments one at a time so that you know what's working and what's not working, and then you can just hold on to the stuff that's useful for you. So first of all, about your healthcare team, and if you wanted to sort of look a bit more at this model, Emerge Australia sort of put a whole lot of stuff together about this, about how to incorporate the people around you into a kind of a useful way. And it's about remembering that you are the centre of your illness, and you can choose who you want to help you, and you can choose what treatment or strategies are going to work for you. You don't have to take everything on board that's presented to you. So some of the people that you might be in your team would be a medical specialist, allied health professionals like occupational therapists, physios, support staff and carers and family members. And some of the things to think about is that one doctor may not manage all aspects of your care. And I know I've talked to people who have a GP who they go to for certain things, but they may also go to an integrative or a holistic practitioner as well to help with some other aspects. Remember, every person's opinion is valuable, but you don't have to use all of them. Some team members might be not useful now, but you might want to keep them on board for, you might need them in the future. And remember that you are the centre of your team. You're the one that dictates which way you go. You're the one that that can say yes or no to what you need. And it's useful, I think, to think about how to work with your doctor. We all know that a 10 to 15-minute appointment at your doctor's is not going to cut the mustard for someone who has a complex chronic illness. So it's some of the things you can think about is if you've got a few things to talk about, book a double appointment. Try to book it at a time of day when you're feeling at your best, when you're going to have most energy. And you can, if it's really going to be a huge, difficult thing to do, you can ask to rest while you're waiting, and if you can organise that before you go. If you bring a support person, which is probably quite a good idea because then you don't have to manage everything about the appointment. But if you do bring a support person, think about, do you want someone to drive you? And if they're coming, do you want them to come in with you, or do you want them to wait in the car? If they're going to come in with you to the doctor, are they going to help you talk, or are they just there to sort of take notes and observe? So thinking about all of those things. And then before you go, a little bit of preparation can really help you optimize what you get out of your appointment. And this is just one template. Not everybody has to use this. But if you're thinking before you go, what's the goal? What do I want out of this time? What are the questions I want to ask? Because I know that on the day it's all going to go right out of my head. Do I need medications reviewed? Do I need new scripts? Do I want to know the results of tests? Do I want to ask for tests? And when's my next appointment? So having some kind of a template like this can help just to organise your thoughts, just to have everything ready before you go so that you can really get the most out of the appointment that you've got. Another thing I talked about was a symptom stepwise approach to symptom management. And again, this looks probably quite a complicated a chart, but it's, again, just another tool. If you're trying to sort out in your own head what's going on, what are the things that are most important? How can I rank the things that are happening to me? Is it the orthostatic issues that are the most troubling for me, or is it my sleep, or is it the pain? You know, if you can rank them sort of numerically, then that can help you sort out in your own head which ones you're going to choose to try and deal with first, and you know, what are the ways to sort of approach some of these problems. As I said before, pacing is the most important skill that anybody can have who is living with MECFS. And it's achieving that correct balance between activity and rest, something that takes a lot of practice to do. And I guess I'd like to just introduce this thought of the undercharged battery here. It's what a lot of people with energy limiting conditions experience this same thing, that they go to bed at night, they plug in the charger, and when they wake up in the morning, instead of being 100% charged, they're well under power. And the battery runs out a lot quicker than other people's batteries, and needs a lot of recharging during the day. And this is quite a good way, I think, to think about the amount of energy you have, and to think about stopping before your battery is in the red. So people who pace well, they're active when they can be, and they rest when they're tired. It's also a part of the skill is recognizing that on the days that you feel really good, that's not a catch-up day. It's not a day to do all of the things that you tried to do on the other days when you're not feeling good, because then you'll definitely burn your battery out. And people who pace well can identify the triggers that cause them post-exertional malaise, and be aware of them before they become an issue. So for some of the triggers for people are physical, or orthostatic, standing around, cognitive triggers, sensory, a lot of overstimulation, oversensory stuff can be a really big trigger. Emotional can be a very big trigger, and I've had people talk to me and say, look, I can walk, I can do physical stuff, it's not an issue, but the minute I have to deal with challenging emotions or a lot of cognitive work, I know I'm headed for a crash. And no trigger can be controlled all of the time. We have to live life. Life gets in the way of things. So the goal of pacing is to minimise our PEM rather than eliminate it. And keeping a diary can be something that can be really helpful in identifying the things that trigger you. And this is the symptom diary that we provide at MECFS Canterbury. I'm sure a lot of people are familiar with it. And what it does over a week is it helps you match up the activities that you do with the way you're feeling. So every day you write down the activities that you do, you keep a note of your heart rate and your sleep hours, and then you rank your symptoms. And in this way, you can start to see patterns emerging. When you're starting to see lots of 4s and 5s, if you look back, you can start to see the sorts of triggers, the sorts of things you might have been doing that might have caused the increase in your symptoms. So some of the things with activity management, some of the things that are useful to think about are radical rest or preemptive resting. So it's about resting before you have something big coming up, resting before you go to a meeting, resting before you have to go and pick up the kids from school, or resting before you do something as well as afterwards. When you're first trying to work out what your energy level is, what your baseline energy level is, it's a good idea to decrease your activity by half to start with. And then if you're not seeing any symptoms, you can sort of gradually increase your activity until you can until you start to be symptomatic. And then that gives you an idea of where your limits lie. And remember that your baseline can actually fluctuate over time, depending on your illness or depending on other things that are going on with you as well. If you monitor objective values like your heart rate, that can be really helpful. Like wearing a device to keep an eye on your heart rate can be really helpful in terms of managing your activities as well. And I was just talking to someone yesterday who said that for her, this is probably the best and the most helpful tool that she's got, And she often looks at her smartwatch during the day to look at her symptoms, her heart rate. And when she sees it going over her actual limit, which was 96, when she sees it actually starting to go over that and sit above that for a wee while, she actually stops what she's doing, sits down and rests until her pulse rate comes back down, and then she resumes her activity. And what she's found is that often her pulse rate will go up before she starts to feel symptomatic. And by watching her pulse rate, she's actually managed to avoid a lot of her post-exertional malaise. So that can be really a helpful kind of objective thing to use in terms of managing your energy. Another thing is to avoid performing healthy. I know that a lot of people hate to sort of admit publicly that they can't do as much as everybody else, but sometimes you've just got to say, oh, I'm going to sit down, I'm going to sit wherever I like, I've got to sit down now, that's my need, or I've got to stop, or I've got to, or you speak up when you're with other people and say, well, actually, I've got to stop now, and I've got to go home, but I'll catch up again later. And then prioritizing your activities as well, thinking about how important is this, how necessary is it, how difficult is this, can I actually do this on my own, am I going to get repercussions, and can I get other people to do this for me or with me? And those are sort of quite good questions to ask. And then last of all, if possible, avoid that pushing through. It becomes such a habit sometimes, but it's really important to stop, listen to your body. And I think this is the real dilemma that we all face. How do you get that happy medium? So perhaps a simpler way to think about pacing is to have this in your mind, the Stop.Rest.Pace mantra. And it's stopping activity before you get symptomatic, resting, take regular rest breaks, little micro breaks. For some people, it's just 5 minutes every hour, just have a wee break, have a breathe, have a whatever, and pacing. So breaking up activities into manageable chunks or mixing things up. So doing a physical thing and then moving to a cognitive thing, or then moving to a physical thing like that. So mixing things up or breaking things up into smaller chunks can be really helpful. And then some days, this is probably as far as it goes. A little bit about sleep. So there's a lot of things that you can sort of think about with sleep. And I think the first thing to do is, if you're having sleep issues, is to go and see your doctor to see, are there underlying sleep disorders that are going on for me that need to be treated. And if you've got very abnormal sleep, you can be actually referred to the sleep clinic. And there is a private sleep clinic as well with a specialist, Dr. Mike I can't say his name, Larvek or something, is one of the sleep specialists in Christchurch. Are there other things going on that are disturbing your sleep? So have you got a lot of pain that needs to be dealt with? Is there a lot of overstimulation, sensory stuff that needs to be looked at? And we all know that when you have post-exertional malaise, your sleep worsens. So it's quite counterintuitive, really. You think, I'm so tired, I'm feeling so awful, but the sleep is harder to achieve. Looking at reversible things. So, these are some of these sleep hygiene things. So avoiding caffeine, alcohol, decongestion, stimulants. Avoid brain work before you go to bed and bright light. Restless leg syndrome and the sleep apneas, they can be, try and get those treated. Sleep hygiene, there's a lot of stuff about sleep hygiene, using sleep apps, making sure your environment is right, it's cool, it's dim, and those sorts of things can be really helpful. And the other thing to help keep your circadian rhythms normal is to expose yourself to bright light during the day. So first thing in the morning when you get up, go and stand outside or stand by a window for 10 minutes so that your body remembers that, oh, it's actually morning, it's time to sleep up, to wake up. And then in the evening, dimming your lights, avoiding screen lights and stuff like that, so that your brain starts to produce a little bit of melatonin to prepare for sleep. There is some medication that can help, and tricyclic antidepressants are the things that are the first go-to for sleep problems, and these are on our community health pathways are recommended. Melatonin, which is the natural sleep hormone that our body produces, can also be taken before bedtime, and melatonin is very good for getting to sleep if you're having trouble getting to sleep, but it doesn't help you to stay asleep. It is recommended that other sleeping medications should be avoided in the long term. They do tend to disrupt sleep cycles, and there can sometimes be problems with dependence and things. But sometimes if you need something to sleep, you need something to sleep. So it's about getting that balance. And again, with MECFS, just be really aware of sensitivities to medication. Start low and slow, as with all of your medication. And here's just a couple of thoughts about having trouble with sleep that I'm sure you can identify with. So cognitive impairment, the brain fog, what can we do about that? Well, sometimes it can be helped by just getting a really good medical workup from your doctor. So just making sure you're not anemic, or that your thyroid levels aren't low, or that your diabetes is under control, or you don't have sleep apnea, all of those sorts of things. Vitamin B12 can be really helpful as well. Do your good pacing, because as with everything else, cognitive dysfunction increases when you have post-exertional malaise. Look at getting other things sorted so that your energy is not being drained by severe pain or chronic sleep disturbance. Make sure that orthostatic intolerance is well managed if possible, because that will increase your brain function. And have a look, if possible, for fitness and restorative movement. And we'll talk a wee bit about that towards the end of the presentation. And then on the other hand, it's such a fine balance, because you want to help, you want to get rid of pain, you want to improve your sleep, but that often involves medication. So sometimes the side effects of medication for pain and sleep can impact on cognitive function. So it's about being very aware of how it's all working and trying to get that balance right. A few things have been shown to be a little bit helpful with brain fog for some people. Some people find these supplements helpful. There's not a lot of strong evidence, but on the other hand, I don't know if there's been a lot of research done on them. But some of these supplements, some people find helpful, and maybe it's just a matter of trying to pick what might be useful for you and trying it out. And low-dose naltrexone and mestinon, which I'll talk about in a minute, can also be helpful for brain fog. And then again, it's sort of just thinking about how to manage it behaviourally. How do I manage the cognitive issues that I have? And it's about doing cognitive things at the best time of the day for you, when you're feeling best. Give yourself more time, try and minimize interruptions, use reminding tools to help you remember things, try and reduce other sensory input, including glare and on screens and devices as well. So orthostatic intolerance, how do we manage that? And for many people say that orthostatic intolerance is the most disabling part of having MECFS, but luckily it is actually the most treatable. There's quite a few things that can be done to help orthostatic intolerance, and probably the most effective. And for some people, this is all they need to do, is increase fluids and increase sodium intake. And this can really have an enormous impact, but it needs to be done constantly. So you need to make sure that you're drinking between 2 and 4 litres a day of fluid, using electrolyte solutions on a daily basis. And some people can tolerate this better than others. Some people feel a bit nauseous with these solutions. Remember with the electrolytes that you do need a certain amount of sugar for the sodium to be properly metabolized and used. So try not to get the sugar-free ones. And just sipping during the day can be enough. And then if you need to do something physical or need to increase your exertion, try and take a little bit more. Compression clothing is also really effective, and the more of yourself that you cover with compression clothing, the better it is. So waist-high skins are probably the most effective way of using compression, because you want to have all the way up to your waist really compressed. But if you can't tolerate that, even knee-high compression socks can be really helpful. And for people who can tolerate exercise, so who don't have severe MECFS or just have POTS without MECFS, exercise is a really good way to manage some of the symptoms. But you start by lying down and can perhaps gradually increase to a more seated or upright position. And another thing that can be helpful is to eat small but frequent meals. So if you have a very large meal, it diverts a lot of your body's blood supply to that area to help with digestion. There's a whole list of medications that are used, and if one doesn't help, then you can sometimes use them in combination or use another kind of medication. Out of all of these, one of these is not available in New Zealand. Droxidopa is not available in New Zealand, but the others are, and they all have varying effects. So if one's not working, go back to your doctor and say, this isn't happening for me, what else can we try? And, make them look at the options. And we do have information on this on a handout if people want this information. And last of all, some other things that you can do for orthostatic intolerance. So, for example, if you're going to be standing around for a bit, or if you need to go and have a shower and you get dizzy in the shower, just have 2 big glasses of cold water beforehand to increase your blood volume, which will help you get through those situations. And some of the other postural sort of counter maneuvers, if you're starting to feel lightheaded or dizzy, crossing your legs, clutching your thighs, doing buttock exercises, up and down, those sorts of contractions and things like that can be really helpful in just shifting some of that blood pooling and getting the blood back into general circulation and helping to get the blood pressure up again. And there's we could spend a whole day talking about some of the other issues, but we'll just touch on them here quickly. A lot of people have a lot of trouble with IBS symptoms or gut issues. It's just about trying to be really healthy with your diet, low in processed food. Some people find eliminating certain foods are helpful. So gluten or dairy-free or histamine-free are some of the diets that some people find helpful, but good, if possible, to get those with the help of a dietitian to get some ideas and supervision. FODMAP diet is another one that some people manage well on as well. Mast cell activation syndrome, probably the best treatment for that is histamines, antihistamines, H1 and H2 blockers. And then pain, again, we could spend a whole session talking about that, but remembering that pain is worse in post-exertional malaise. So again, using good pacing to avoid that pain flare. using a multi-pronged approach. So it's not just looking at medication, but heat, cold, physical therapies, TENS machines are helpful for some people, relaxation, meditation, and if pain is really severe and not well managed, ask your GP to refer through to the pain clinic. And with medication, there's a wide range of different kinds of medications. Opiates are not particularly helpful for people with pain and MECFS or fibromyalgia. So some of the other things, LDN, tricyclics, medical cannabis, muscle relaxants, even anti-epileptic medications can be helpful. So as we've said earlier, MECFS is not a psychological disorder, but it's a life-changing illness, and there's significant losses involved. And as we said, it can be really impactful on our mental health, trying to navigate through an illness that's so unrecognised and so unpredictable and so impactful. So there's a few things that can be helpful. Remember that there is funded counselling available through your GP, and they should be able to organise that. Keeping in mind that a lot of anxiety and a lot of the symptoms that we feel can be due to dysfunction of our autonomic nervous system. It makes everything race, it makes everything feel tense. So mindfulness, breathing or relaxation techniques can be very helpful in that kind of situation. Try and reduce your post-exertional malaise. Try and prepare some responses in advance to some of the unhelpful comments that people have when they're trying to be sympathetic, perhaps. Try and get outside on a day like this, for example, get some of that vitamin D, soak it up. Gorgeous day that can really help with mental health. Gentle stretches or movements. And there's things like medication, of course. There's phone lines that you can call. There's the MECFS community on our Facebook group. And if you feel that you're really struggling, you can ask your GP for a referral to mental health services. And at the moment, in MECFS also have an intern psychologist on staff as well, who is working part-time and also available for help. And, sometimes it's really difficult to think, when someone says, "Oh, how are you?" And you say, "Oh, fine, thanks." Well, actually, I'm not fine. But how do we convey that to people in a way that people might understand? And just some responses that might be helpful. Quick word about supplements. Supplements are a bit tricky because there's not a lot of evidence to support their use, and they can be very expensive, and it can be really difficult sometimes to justify to yourself, the use. But then you think, they might help. So it's important to sort of do your due diligence, really investigate well what's out there and what there is to support their efficacy. Remembering that some supplements and treatments and therapies can do harm, and be very, very careful. And so some guidelines that you can think about is, first of all, probably discuss it with your GP. They don't always know about them, but sometimes they do. Add one at a time, so then you know what's working, what's not. Start on very low doses, same with any kind of medication. And if you're getting any negative reactions or symptoms, then stop. And sometimes it can be helpful to monitor the use, because if you've been taking something for a month, sometimes if there is change or good change, it can be very incremental and very hard to remember how you were feeling a month ago. So journaling and being very sensitive to changes can be quite helpful. And if you're still really unsure, you're thinking, is this helping or not helping? If you stop it and then take pay very close attention to how you're feeling, that can be helpful in working out whether or not it's been useful. And these are just some of the possible supplements. And as I've said, it's really important to talk to your doctor before trialling them. And vitamin D, you should probably get a blood test first to make sure to find out if you are low. Magnesium can be helpful for sleeping. Vitamin C, vitamin B12 and B multi can be very helpful for brain fog. The injectable form is probably more effective. And if people are interested, we have a guideline that you can look at and take to your doctor for use of vitamin B12 in MECFS. Be very careful of iron because you can overdose on it. So don't take iron because you think it may help your energy. Just make sure that you do actually have a deficiency. CoQ10 and NAC have been found helpful by some people. Antihistamines, particularly if you think you've got some mast cell activation going on. Melatonin, as we discussed, for sleep. And evening primrose oil apparently has been found to be helpful with some people with joint pain. There are two medications at the moment that are used off-label quite a lot for MECFS. One of them is low-dose naltrexone and the other one is Mestinon. And low-dose naltrexone, the actual naltrexone has been used for people coming off opiate addictions, but for MECFS, it's used at a much lower dose, a microdose really, and has a good safety profile. And some people have found it being helpful with pain, fatigue, sleep, and brain fog. But probably only 1 in 3 people get benefit from it. And you have to actually take it for quite a long time before you see whether or not you're getting any effects. It's a very slow incremental increase over time to see if it works for you. Mestinon is used for myasthenia gravis, but it's been used off-label for POTS and ME, long COVID, fibromyalgia, EDS, and with some quite good effects. And again, we have information sheets on both of these medications if you were interested in finding out more or wanted to chat to your doctor about trialling them. Just a quick word about things that are not recommended. We're nearly finished. Graded exercise therapy was used for a long time as a treatment for MECFS. It is not recommended. Most people who have done graded exercise therapy have found no benefit or got significantly worse. Cognitive behavioural therapy, again, is no longer recommended as a treatment for MECFS, but it may be helpful for people who want to find some strategies in terms of how to cope with living with a chronic illness. From that point of view, it could be quite useful. And the lightning process, which is to be found online, has been specifically mentioned in the NICE guidelines in the UK as an inappropriate treatment for MECFS. And a lot of these neuro-linguistic programming therapies tend to make people crash and risk pushing people into a more severe symptom state. So be very, very careful. And it's, I guess, if you're thinking about a commercially available treatment, think very carefully about it, because we do know that MECFS doesn't have a known cure. So anyone claiming to cure, you can approach with a fair degree of skepticism. Quickly, tips for safe exercise. Some people want to do a bit of exercise. So if you do, you should be absolutely stable in terms of your symptoms and your post-exertional malaise. you should be in a quite a good place in terms of how you're sort of managing everything. Experiment to find what works for you. So gentle activities and exercises lying down are good because they use less energy. Keep an activity diary so that you can see what you're doing and how it impacts on how you're feeling. And if you're increasing your activity level, the recommendation is try the slight increase in activity level, then don't do it for 2 days and observe very carefully how you're feeling. And if you're feeling okay with no post-exertional malaise, try that increased activity again and then observe for 2 or 3 days to see how you're feeling. If you continue to feel well, then you know that you can safely exercise at that level or move at that level. We should say movement rather than exercise. Stop before you feel you get any symptoms. Remember that your level of exercise tolerance will vary probably from day to day, and listen to your body. Stop before you feel symptomatic. And then, of course, some days the best place to be, or the only place to be, is in your bed, and it has got a multifunctional, many functions, the bed, including an office and a cafe, which I thought was pretty good. Last of all, how can you make a meaningful life in the confines of having a chronic illness? And everybody's experience of this is different. Everybody finds their own way eventually. But some things that have been found to sort of be helpful, that other people have found helpful, is to make connections. Try and have significant other people in your life that make you feel good, that you can connect with, and that notice if you're not around. Practice gratitude. Find the things in your life that are going well, and for some days it might just be the sun is shining, and then find what you can do and invest in that. Sometimes there's so much loss, it's hard to actually move away from the loss, but find what you can actually do and focus on that. And last of all, hold on to hope. In this part of our history, there's more research, more stuff going on in the MECFS and long COVID space than there ever has been, and there's some really interesting and discoveries being made, and it won't be long before this is followed up by effective treatments. We have a lot of resources that online that you can find out more about MECFS and what can help. And I guess in summary, the main sort of points that I really want to make is it's really important to have a doctor who understands what you're going through. If you can find a doctor who understands it and is willing to listen to you, that's gold. The core symptom of MECFS is post-exertional malaise. People with MECFS experience lots of things. There's lots of things going on. It's not just fatigue. There's no diagnostic test yet, but we do have diagnostic criteria. The causes are complex, not fully understood. There's no cure. But managing your symptoms can help you stabilize and improve your quality of life. And the most important management strategies are pacing and rest to try and reduce the intensity and frequency of post-exertional malaise. So some good places to go to get more information. And thank you very much for listening to the presentation today.